Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can use this link to access the YouTube channel, which is freely downloadable. We also have a Telegram group. You can join this group to access all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the Google Drive and the YouTube. These are the disclaimers, and we are with phase 3, which is recorded pathology lectures. And today we have Pursue 9W, which is cytopathology, and we are streaming from the Department of Pathology, Dr. YSPGMC, Nahan, Himachal Pradesh. And today the topic is Cytology of the Thyroid, the Bethesda Category 3 and Category 4. And to talk on that, we have Dr. Sudha Sharma. She's an MD from PGI Chandigarh, a DNB in Pathology. She's an assistant professor at the Department of Pathology at the Dr. YSPG Medical College, Nahan, Himachal Pradesh. Her areas of interest is cytopathology and gynecological pathology. She's got multiple publications in indexed national and international journals. She's a life member of IAC and IAPM. This is the second lecture of Dr. Sudha Sharma on cytology of the thyroid. So with this, I would request Dr. Sudha Sharma, ma'am, please start your lecture on cytology of thyroid, Bethesda Category 3 and Category 4. Over to you, ma'am. Thank you.
Good evening, everyone. This is the second lecture on thyroid cytology. In this lecture, I will give an overview on the Bethesda system for reporting thyroid cytopathology 2023 and discuss the Bethesda categories 3 and 4. This is the outline of my talk. I will brief regarding the new third edition of the Bethesda system for reporting thyroid cytopathology. We had discussed the first two categories in the last class. I will brief regarding the changes in category 1 and 2 in the new Bethesda, and subsequently I will discuss in detail the Bethesda categories 3 and 4. So as we have discussed earlier, the first edition of the Bethesda system for reporting thyroid cytopathology was published in 2007, which established a standardized reporting system with a limited number of diagnostic categories for thyroid FNA specimens. This was further revised in 2007, and there were 6 diagnostic categories, 3 of which had 2 names, and each lab was allowed to adopt any one name out of the 2 categories. That is, category 1 was non-diagnostic or unsatisfactory, and any lab could choose any one of these names for practice. Similarly, category 3 had 2 names, AUS or FLUS, and category 4 had 2 names, follicular neoplasm or suspicious for follicular neoplasm. Each of these categories had an implied cancer risk that was linked to an evidence-based management guideline. The Bethesda system has been further revised in 2023, and the third edition has been published. In this edition, there is refinement of diagnostic categories, recommended management strategies like molecular testing, repeat FNA versus surgery, and the implied risk of malignancy. And this change is based on the data that clinicians are increasingly favoring surgical lobectomy, limiting the routine use of radioactive iodine, and considering non-operative monitoring approaches for small thyroid malignancies. So what is new in the new Bethesda system for reporting cytopathology 2023? The diagnostic categories have been given a single name. Each of the diagnostic categories has now been given a single name. Like category 1, that is non-diagnostic or unsatisfactory, is now termed as non-diagnostic. There is no alternative term for these categories. Similarly, category AUS/FLUS is now termed as AUS only, and category FN/SFN is now termed as follicular neoplasm only. Another change in this new Bethesda is that the data informing use of the Bethesda system of reporting thyroid cytopathology in the pediatric population is now included. This change has been done because the risk of malignancy is higher in children compared to the adults, and so adjusted risk of malignancy estimates should be applied for children. Risk of malignancy estimates have also been refined in the new Bethesda, and this is based on the incorporation of more extensive published data since the second edition of the Bethesda system. The AUS category has been now formally subcategorized into two types of categories based on the risk of malignancy, that is AUS with nuclear atypia versus AUS other categories, which further includes 4 different types of subcategories. So cases with having AUS with nuclear atypia have much higher risk of malignancy than the AUS present in other types of categories. The terminology used in the Bethesda system for reporting thyroid cytology has been harmonized with the latest 2022 WHO classification of thyroid neoplasms whenever possible. All high-grade follicular-derived carcinomas, including poorly differentiated thyroid carcinoma and differentiated high-grade thyroid carcinomas, have been described in detail in the chapters. New chapters covering clinical perspectives, imaging studies, and use of molecular and other ancillary tests have been incorporated, and new images have been added to better illustrate the diagnostic criteria and cytologic features. So these are the diagnostic categories for the Bethesda system for reporting thyroid cytopathology 2023. Which gives a single name for each of the categories, that is category 1 is non-diagnostic, category 2 benign, category 3 AUS or atypia of undetermined significance, category 4 follicular neoplasm or FN, category 5 suspicious for malignancy, and category 6 is malignant. There has been a change in the risk of malignancy for each of the diagnostic category based on the recent information available, and accordingly there is a slight change in the management in each of these categories. Data informing the use of risk of malignancy in pediatric population is now included. Risk of malignancy in children is higher in adults, and accordingly management guidelines they have been provided. Reclassification of some FVPTs, that is follicular variant of papillary thyroid carcinomas, as NIFTPs has implication for the implied risk of malignancy, as the NIFT tends to behave in an indolent fashion. So based on the published literature, there is an overall reduction in the risk of malignancy if the nodule is diagnosed as NIFTP, if the nodule which is diagnosed as NIFTP is excluded. So now I will briefly highlight the changes in the categories 1 and 2 in the Bethesda system for reporting thyroid cytopathology 2023. So we have already discussed in detail this category 1, that is non-diagnostic category. Alternative name for this category is not available now. The subcategories remain the same. The definition is the same, and the adequacy criteria of at least 6 groups of well visualized, that is well stained, undistorted and unobstructed benign follicular cells is required. Each group composed of at least 10 cells. The previous Bethesda stated that these cells should be preferably present on a single slide. However, the new Bethesda says that these 6 groups of 10 follicular cells can be present on one slide, or they may be distributed among several slides for adequacy determination. The exceptions remain the same. Risk of malignancy is slightly increased compared to the previous Bethesda of 13% with a range of 5 to 20%. The management remains the same. A repeat aspiration with ultrasound guidance is recommended, and it is diagnostic in most cases, but if they continuously remain undiagnostic, excision is required if they persistently remain non-diagnostic. The second category which we have discussed previously is the benign category. Again, the subcategories remain the same, except that the term benign follicular nodule has now been changed to follicular nodular disease. This is in accordance with the latest 2022 WHO classification of thyroid neoplasms, where the term BFN or benign follicular nodule has been replaced by FND or follicular nodular disease. The other subcategories remain the same. This is the most commonly encountered entity in thyroid cytopathology, and whenever we give the term follicular nodular disease, it can include a group of benign lesions, which we have already discussed previously. The definition of the benign category remains the same, and risk of malignancy is slightly increased. Previously it was 3%, now it is 4% with a range of 2 to 7%. Management remains the same. So now we are coming to the Bethesda category 3 or ATP of undetermined significance. So previously another alternative term, FLUS or follicular lesion of undetermined significance was also there, but now the new Bethesda gives a single term to category 3, that is ATP of undetermined significance. So this is an important there is an important change in this category, that is that the ATPia in AUS is now been categorized into two categories, that is ATPia which is nuclear, that is nuclear ATPia, and nuclear ATPia other than nuclear features, that comes in the others. So this others category further includes architectural atypia, oncocytic atypia, lymphoid atypia and NOS categories. So we have basically two categories in the AUS diagnostic category, AUS related to nuclear atypia and AUS related to other categories, which include 4 subcategories. The term cytologic atypia, which we used earlier, is no longer used. Now the term nuclear atypia is used. And why it is important to distinguish between these two categories? Because AUS aspirates with nuclear atypia have more than twofold risk of malignancy compared with the AUS cases with other types of atypia. And also oncocytic predominant AUS has much lower risk of malignancy than other AUS patterns. What is the definition of ATP of undetermined significance? This term is reserved for specimens that contain one or more of a heterogeneous group of findings that raise concern for neoplasm or malignancy, but are insufficient to be classified as a follicular neoplasm, suspicious for malignancy or malignant. However, the findings overall are more marked than can be ascribed confidently to benign changes. So overall the findings are much higher compared to the benign changes, but they cannot be categorized into any of the categories follicular neoplasm, suspicious for follicular neoplasm or malignant. So those cases we will categorize them as AUS. So these are the two broad categories of AUS. AUS with nuclear atypia. It is given in cases which raise a low level of concern for papillary carcinoma or NIFTB. And the second category is AUS other, in which other features which are non-nuclear result in AUS interpretation. And it again includes 4 subcategories, as I told: architectural atypia, oncocytic atypia, atypical lymphoid cells and atypia NOS. So what are the criteria for calling a sample as AUS? So first we'll talk about AUS with nuclear atypia. So there are various scenarios which can be discussed under this category, that is AUS with nuclear atypia. The first scenario is if there is focal nuclear atypia. Most of the cells are showing benign changes, but there are focal areas which show this type of irregular nuclear margins, pale chromatin, grooving, but there are no pseudo inclusions, there are no psammoma bodies, there are no papillae. So these cases will be grouped under AUS with nuclear atypia, which is focal. We should keep in mind that these type of changes can also be seen in certain conditions like lymphocytic thyroiditis. So if you have changes of lymphocytic thyroiditis elsewhere, then a diagnosis of AUS with nuclear atypia should not be given. But if you do not have any evidence of lymphocytic thyroiditis anywhere, then and you have some foci of nuclear changes which do not conform to the morphology of papillary carcinoma, you should classify them as AUS with nuclear atypia, which is focal. Then another scenario which we can see is there is extensive nuclear atypia, but the nuclear atypia is mild. So you can see in this picture there is extensive nuclear changes, nuclear grooving, no nuclear inclusions, no pseudopapillae, but there is mild nuclear atypia present throughout the thyroid follicular cell. So such cases they should be categorized as AUS with nuclear atypia, and this is in this particular example molecular testing was done and it was positive for HRAS mutation, and on lobectomy it came out to be as NIFTP. So it is important to look for the nuclear changes whenever you look at any thyroid FNA. Then another scenario where you can have nuclear atypia is the presence of atypical cyst lining cells. So atypical, the cyst lining cells themselves, they can show many reparative changes, like they can have abundant cytoplasm, enlarged nuclei, prominent nucleoli, intranuclear pseudo-inclusion can be seen, like is seen in this particular cell. But sometimes these changes may be very marked. So you may not be able to differentiate them from a malignancy. So in those cases, you have to classify them as atypia, atypia of undetermined significance with nuclear changes. Then another scenario where we can have AUS with nuclear atypia is the presence of histiocytoid cells. So these histiocytoid cells can be seen in cystic papillary carcinomas. So if you have this type of histiocytoid cells which may be present in clusters, they may form microfollicular arrangement or they may be singly scattered. And these cells are usually larger than histiocytes. They have round nuclei compared to the bean-shaped nuclei, kidney bean-shaped nuclei present in histiocytes. They have higher NC ratio, glassy cytoplasm, and they do not have any microvacuolization or hemosiderin which is present usually in the histiocytes. So if you have such type of histiocytoid cells and you do not have any definite nuclear features in the follicular epithelial cells, then you should categorize those cases under the category of AUS with nuclear atypia, because there is high chance that you may have an underlying cystic papillary carcinoma in these cases. And the last scenario in this particular category is if you have both nuclear and architectural atypia. So mild nuclear atypia may be present along with architectural atypia. What do you mean by architectural atypia? The most common architectural features of architectural atypia is the presence of microfollicles or crowded three-dimensional groups. So if you have both these features, then also it will be categorized under the category of AUS with nuclear atypia. And both of them, if they are present, then also they are grouped under this category, because the risk of malignancy is similar whether the architectural atypia is present or not. So the risk of malignancy basically depends on the nuclear atypia. So it is, if both of them are present, then also they will be grouped under AUS with nuclear atypia. Then the second category under AUS is AUS others, which includes the atypia other than the nuclear atypia, and this includes 4 types of atypias, that is architectural atypia, lymphoid atypia, oncocytic atypia and NOS. So when do you call architectural AUS with architectural atypia? So architectural atypia is mainly in the form of microfollicles or three-dimensional crowded groups. So the first scenario where we can have architectural atypia is if you have a scanty specimen, cellularity is scant, with rare clusters of follicles which are forming microfollicles or three-dimensional groups with scant colloid. So in these cases, there is a possibility that if you get a higher cellularity, it may come out to be a follicular neoplasm. So these cases should be grouped under cases of AUS with architectural atypia. Then sampling of an intrathyroidal parathyroidal lesion may also present with this particular pattern, and it is difficult to separate from thyroid follicular lesion on morphology. However, the presence of endothelial cells within the clusters of follicular epithelial cells, bare nuclei, stippled chromatin may help to differentiate parathyroid adenoma from follicular lesion of the thyroid. Then the next scenario where we can have AUS with architectural atypia is a moderate to markedly cellular specimen. So the first example we saw was a scant specimen where most of the arrangement of follicular cells is in the form of microfollicles or crowded follicular cells. The second scenario is if we have a moderate to markedly cellular specimen which has architectural atypia in the form of microfollicles or crowded cellular groups, but there is not a marked predominance of these clusters. That is, at least, so according to the WHO 2022, at least 70% of the follicular cells should show architectural atypia to call a diagnosis of FN. So if you have less than 70% of follicular cells showing architectural atypia in a moderate to markedly cellular specimen, it should be called as architectural atypia, AUS with architectural atypia. And DICER1 mutated nodules, they are commonly associated with this particular pattern as they have architectural atypia with minimal to no nuclear atypia. And this is particularly seen in pediatric samples where DICER1 mutation is common in both multinodular goiter and follicular neoplasms. Then another scenario where we can have AUS with architectural atypia is if you have focally prominent microfollicles without nuclear atypia, but the overall proportion of microfollicles is not sufficient for a diagnosis of follicular neoplasm. And when this particular situation occurs when a particular slide or focus looks different from the rest of the aspirate. So most of the aspirate is showing benign follicular cells, but one particular slide or one particular area shows predominantly follicular cells. So in those cases, there is no nuclear atypia but only architectural atypia which is focal. So in those cases, you will call it AUS with architectural atypia. And you should remember that this type of pattern can also be seen in the setting of multinodular goiter, where you have predominantly macrofollicular pattern of arrangement of the cells, and one or two foci may show predominantly microfollicular pattern. But if overall, if you have a predominant macrofollicular pattern, you should not call it AUS. You should call it and call it benign, and you should diagnose it under the benign categories, that is category 2. Then the second type of atypia in the others category is oncocytic atypia. So here also there is presence of oncocytes. Oncocytic atypia means the presence of oncocytes. So here also you can have several scenarios. First is presence of a sparsely cellular aspirate. So you have some oncocytic cells, the cellularity is low, but whatever cells are there, they are comprised of exclusively of oncocytic cells, and there is no colloid, minimal or no colloid. So in such a scenario, there is a concern that the sampling may not be adequate, and on extensive sampling, maybe we get a oncocytic neoplasm. So in such cases, it is better if the repeat FNA is not possible, then categorization of AUS with oncocytic atypia should be given. The second scenario is if you have a moderate or markedly cellular specimen which is composed exclusively or almost exclusively of oncocytic cells which are more than 70% of all the follicular cells. So in such cases, you will categorize them as oncocytic follicular neoplasm. However, the dilemma is that the clinical setting is suggesting lymphocytic thyroiditis or multinodular goiter. So the clinically it is a case of lymphocytic thyroiditis or multinodular goiter, but you are getting more than 70% of follicular cells, and there are no lymphocytes in the background, there is no colloid in the background. So such cases will have to be categorized under AUS with oncocytic atypia. However, if the oncocytic cells are in flat sheets without nuclear atypia and there is abundant colloid, so in the previous scenario I told you that there is no colloid, but if you have abundant colloid in such a situation and you have a clinically there is a suspicion of multinodular goiter, the diagnosis of benign category should be given. Similarly, if there is a clinical evidence of lymphocytic thyroiditis but lymphocytes are absent in your smear, then you should go for a repeat aspiration, and the repeat aspiration we are likely to get some lymphocytes, and a possibility of lymphocytic thyroiditis can be given. And another situation is that if you have multiple nodules in the same patient. So if you have multiple nodules in the same patient and you are getting sheets of oncocytic cells with multiple nodules, the diagnosis of oncocytic follicular neoplasm is less likely, because concurrent oncocytic follicular neoplasms do not occur commonly. So in such cases, with sheets of oncocytic cells, patient having multiple nodules, a diagnosis of AUS with oncocytic atypia should be given, and it should be presumed that multinodular goiter with multiple hyperplastic oncocytic cell nodules or lymphocytic thyroiditis with oncocytic metaplasia, that should be ruled out first before considering it as a case of oncocytic follicular neoplasm. And the third category of atypia is atypia NOS. In atypia NOS, a minor population of follicular cells shows nuclear enlargement, often accompanied by prominent nucleoli. However, it does not raise the concern for papillary carcinoma. So this type of findings, they may be seen in patients with Graves' disease, which are treated with methimazole, showing marked nuclear enlargement and anisonucleosis. And they can also be seen in patients with history of ionizing radiation to the neck. So if you have this type of history in the patient and seeing this type of atypia, these cases should be categorized in the benign category. However, most of the times we do not have the history of the patient. So without the history, having such type of atypia which cannot be, does not qualify to be called a papillary carcinoma, classify it under atypia NOS. And please note that in case of Hashimoto thyroiditis or lymphocytic thyroiditis, the metaplastic oncocytic cells, they can have pronounced nuclear variation, nuclear size variation. They can have enlarged nuclei, smudged chromatin, and nucleoli can be present in some cases. So these cases should be considered benign. They should not be classified under the AUS category if you have a straightforward case of lymphocytic thyroiditis. Then another scenario in the category of atypia NOS is the presence of semomatous calcifications. So these semomatous calcifications, if they are present in the absence of follicular cells with nuclear features of papillary carcinoma, only the semoma bodies are present and the nuclear features of papillary carcinoma is not present in the follicular epithelial cells, then the category of AUS NOS should be given, because overall predictive value of semoma bodies for papillary carcinoma is about 50%. So in the absence of a population of follicular cells with nuclear atypia, category of AUS should be given. And a mimic of semomatous calcification is the presence of lamellar bodies of inspissated colloid. So the semoma bodies calcifications, they should be differentiated from colloid, inspissated colloid bodies which may be present in the thyroid FNA. The fourth subcategory in atypia others category is the atypical lymphoid cells to rule out lymphoma. So this particular category is given if the atypical lymphoid infiltrate is present, but the degree of atypia is insufficient for the category of suspicious for malignancy. So in such cases, a repeat aspirate should be done for flow cytometry, and a differential diagnosis in such lesions is the presence is thymic lesions. If thymic lesions are present, you can have similar kind of sheets of lymphocytes. So you have to differentiate between the two. So you should know the AUS category. Sorry, the plus is not used. So AUS usage, it varies widely. Comprises 1 to 22% of thyroid FNAs, and it has been proposed that the upper limit of AUS should not exceed 10% in a lab. So the cases of AUS should not be more than 10% in a particular lab. And another quality measure for AUS is that the AUS to malignant ratio should not exceed 3. So AUS upper limit should not be more than 10% among the total thyroid FNAs, and the AUS to malignancy ratio should not exceed 3. So AUS interpretation should be of the last resort. Some Hurdle cells or cyst lining cells, if you have some Hurdle cells or cyst lining cells which are showing some atypia, but you have evidence of benign follicular cells elsewhere and you have abundant colloid in the background, do not call it atypia NOS. Only if you have Hurdle cells in sheets, you do not have any evidence of multinodular goiter or lymphocytic thyroiditis, you have markedly atypical cyst lining cells which raise the suspicion of malignancy, only those cases you should call it AUS. Otherwise, you should give a benign diagnosis. Also, if you have a particular history of radiation or Graves' disease or any other entity, you should call it benign. Similarly, in case of multinodular goiter, you can have a mixed architectural pattern, but if you have predominantly macrofollicular pattern with some areas showing microfollicular pattern, it should be classified as benign. In papillary projections, if they are seen, they can be seen in papillary carcinomas, but merely the presence of papillary projections should not tempt us to call it papillary carcinomas, because papillary projections can be seen in benign papillary hyperplasias, Graves' disease, as well as other hyperplastic thyroid nodules. Then sometimes specimen preparation artifacts can raise concern for AUS. For example, air drying of the alcohol fixed smears. Sometimes the alcohol fixed smears get air dried initially, so that can result in enlarged looking nuclei which look pale with irregular nuclear outlines. And also excessive blood clotting can give false impression of architectural overcrowding due to entrapment of cells in the clot, and presence of fibrin strands can give false impression of nuclear grooves. So in such cases it should be repeated. So also it should be kept in mind that the most common malignancy developing in patients with Hashimoto thyroiditis is papillary carcinoma. Hurdle cell carcinoma in the setting of Hashimoto thyroiditis is very rare. So cases of Hashimoto thyroiditis showing nuclear atypia, any atypical collection of Hurdle cells, they should be diagnosed as benign and they should not be called as Hurdle cell carcinoma. The risk of malignancy in the AUS category varies. In the adults, it's 22% with a range of 13 to 30%. In children, it is 28% with a range of 11 to 54%. And the risk of malignancy is also dependent on the subtype of AUS. So AUS with nuclear atypia has a much higher risk of malignancy of 36 to 44%, and AUS with other patterns has a risk of malignancy of 15 to 23%. Molecular tests have an important role in these cases, and samples with negative molecular results have a low risk of malignancy of 3 to 5%. So how do you manage these cases? Repeat FNA can be done, molecular testing can be done, diagnostic lobectomy or surveillance can be done depending on the individual case. Molecular testing can reduce the need for diagnostic surgery, and because AUS aspirates frequently have negative molecular test results. So if you have negative results, you may not be diagnostic surgery may not be required. Molecular testing of pediatric thyroid AUS nodules is important because molecular landscape is distinct from the adults, composed largely of receptor tyrosine kinase fusions, and these provide high sensitivity and adequate specificity for malignancy detection in pediatric aspirates. So this was about category 3, that is atypia of undetermined significance. Now we come to category 4, that is follicular neoplasm. Again, the alternative term suspicious for follicular neoplasm has now been removed. So this category follicular neoplasm shows overlapping cytologic features between various follicular pattern lesions. So various follicular pattern lesions can be grouped under this category, that is follicular nodular disease, follicular adenoma, FVPTC, follicular thyroid carcinoma, and NIFTP, or non-invasive follicular thyroid neoplasm with papillary features. The goal of this category is to identify all potential follicular carcinomas and refer them for appropriate follow-up, most often a diagnostic lobectomy. So FNA can be considered a screening test, selecting for surgery those nodules with a greater probability of malignancy. That is, all potential FBPTC, FTC, that is follicular thyroid carcinoma, and NIFTP should be screened, and we should be able to screen these and advise diagnostic surgery. The final diagnosis depends upon the lobectomy, because we know capsular or vascular invasion is the sine qua non of follicular carcinoma. So we cannot differentiate it between follicular adenoma or carcinoma on FNAC. The definitive diagnosis is given on histopathology. Overall, the follicular neoplasms constitute only 7% of all the thyroid FNACs in most cytopathology laboratories. So what is the definition of this category? The smears consist of moderate to markedly cellular aspirate comprised of follicular cells, most of which are arranged in an altered architectural pattern, characterized by significant cell crowding or microfollicular formation, trabeculae or single cells. So sample should be at least moderately cellular. Cases that demonstrate suspicious or definitive nuclear features for papillary carcinoma are excluded from this category. So if you have features of papillary carcinoma, nuclear features, then those cases should not be grouped under FN, but they should be classified as suspicious for malignancy or malignant. Follicular pattern aspirates with mild nuclear changes like increased nuclear size, nuclear contour irregularity, or chromatin clearing can be classified as follicular neoplasm as long as true papillae and intranuclear pseudo-inclusions are absent. So if you have true papillae or intranuclear pseudo-inclusions, then they should be categorized under the category suspicious for malignancy. Otherwise, we can classify under category 4 with the note that the possibility of NIFTP or FBPTC cannot be excluded. So what is the criteria for classifying any neoplasm as follicular neoplasm? The first criteria is the specimen should be moderately or markedly cellular. Then architectural features, there should be significant alteration in the follicular cell architecture with cells arranged in microfollicles. So you can see these cells, they are arranged in microfollicles. So what are microfollicles? Microfollicle is defined as flat or three-dimensional groups of less than 15 follicular cells arranged in a circle that is at least 2/3 complete. And a very important defining feature of microfollicle is the presence of crowding and overlapping of the follicular cells. So the follicular cells should be crowded, overlapping cells, three-dimensional groups or flat groups of less than 15 follicular cells which are arranged in a circle at least 2/3 complete. So these are all microfollicles. You can see the nuclear overlapping and formation of this circle composed of less than 15 follicular epithelial cells. Sometimes small amount of colloid, which is this pinkish thing, you can see it can be present within the microfollicle, and usually the microfollicles are of uniform size. Then follicular cells, they can also be present in crowded groups. They can be present in trabecular arrangement, or rarely they can be present as single cells. Cytoplasm is scanty or moderate. Sometimes oncocytic changes may be present, but they are usually focal. And if significant oncocytic changes are present, the category oncocytic follicular neoplasm should be considered. So nuclear features of follicular neoplasms can vary, and in the current Bethesda categorizes them into two categories. First is the most common scenario, that is the typical follicular neoplasm scenario, where the nuclei are normal sized and round nuclei with clumped chromatin, slightly hyperchromatic, and absent or inconspicuous nucleoli. So this is the most common scenario, or the typical follicular neoplasm scenario. The infrequent scenario, or the potential NIFTP or FBPT scenario, in this scenario there is mild or focal nuclear atypia. So nuclear atypia, by nuclear atypia means changes in the nuclear shape, elongated nuclei, irregular nuclear margins, sometimes grooves can be seen, like seen in this particular case. Nuclei can be enlarged, there may be overlapping of the nuclei. Pseudo inclusions are rare, but sometimes they may be present. Chromatin clearing can be seen, margination of the chromatin towards the sides, and prominence of the cell membrane can be seen, and sometimes conspicuous nucleoli can also be present. So if all these changes are present, the possibility of NIFTP or FVPTC should be given in these cases. Colloid is usually scant or absent in follicular neoplasms. Cystic degeneration is unusual, but it can sometimes be present in the form of foamy macrophages. This is in contrast to the oncocytic follicular neoplasms, where the cystic degeneration is commonly seen. So a few words about NIFTP. NIFTP was originally described in 2006. It has an indolent clinical behavior and should not be considered malignant. Previously, it was known as encapsulated FVPTC. The third edition intends to increase the awareness of diagnostic clues to a potential diagnosis of NIFTP, and when it is suspected, should be put in the FN diagnostic category with a facultative comment in the report raising this diagnostic possibility. The cytologic criteria are overlapping between NIFTP and FVPTC, and cytologically it is not possible to differentiate between the two entities. However, we can differentiate between NIFTP or FVPTC from benign follicular nodule or papillary thyroid carcinoma based on the nuclear features. So in benign follicular nodules, no nuclear atypia should be seen with the exception of lymphocytic thyroiditis, whereas in NIFTP or FVPTC, nuclear atypia is seen. And in conventional PTC, marked nuclear atypia is usually seen in the form of nuclear clearing and multiple nuclear pseudo-inclusions. And true papillae can be seen, semoba bodies can be seen, which excludes NIFTP and strongly favors PTC. So if you have no nuclear atypia, except in cases of lymphocytic thyroiditis, a diagnosis of benign category should be given. And if you have marked nuclear atypia in the form of multiple nuclear pseudo-inclusions, nuclear clearing, papillae or semoba bodies, then a possibility of PTC should be favored. And if you have intermediate nuclear features with no pseudo-inclusions, no prominent pseudo-inclusions, no true papillae, no semoba bodies, then give a possibility of NIFTP or FVPTC. So few words about the molecular features of follicular neoplasms and NIFTP. Follicular patterned thyroid neoplasms, that is follicular adenoma, follicular thyroid carcinoma, NIFTP and FVPTC share many molecular alterations. The most common somatic mutations being point mutations in the RAS gene family and PPARG rearrangements. NIFTP is characterized by alteration in RAS in up to 60% cases, PAX8 PPARG in 30% cases and THADA in 30% cases, whereas BRAF V600E mutation and RIT fusion are absent in NIFTPs. So molecular testing of follicular neoplasm cases can be helpful to refine the management decision making. The risk of malignancy ranges from 20 to 50% with an average of 30%, and this range can be 0.2 to 30% lower if excluding NIFTP in the risk of malignancy calculation. So what will be the differential diagnosis of follicular neoplasms? First are the parathyroid lesions. As we have seen earlier also, these lesions can resemble the follicular neoplasms. They are often present in microfollicular arrangement and crowded groups. However, you have to differentiate them based on the nuclear features, presence of salt and pepper chromatin. Crowded trabeculae can sometimes be seen, absence of colloid, and on IHC they will be positive for PTH and GATA3 and sometimes positive for chromogranin, synaptophysin and CD56, and they will be negative for thyroglobulin, TTF1 and calcitonin. Other rare lesions like paragangliomas, hyalonizing trabecular tumors and metastatic low-grade carcinomas can also be confused with follicular neoplasms. Management is in the form of diagnostic surgical excision or lobectomy. After consideration of clinical and sonographic features, molecular testing may be used to supplement the malignancy risk assessment in lieu of proceeding directly with surgery. So another group under the group of follicular neoplasm is oncocytic follicular neoplasm, which was previously also called Hurther cell neoplasm or suspicious for follicular neoplasm. The term Hurther cell has been removed and a single name has been given to this particular entity, that is OFN or oncocytic follicular neoplasm. So what are oncocytic cells? They are also called Ashkenazi cells and oxophilic cells, and they are defined morphologically as thyroid follicular cell with abundance of finely granular cytoplasm that reflects an excessive number of mitochondria. So you can see these follicular epithelial cells showing abundant granular cytoplasm, and this cytoplasm represents the excess amount of mitochondria. They have enlarged nucleus with a prominent nucleolus which can be central or eccentric. In view of the recent changes in the 5th edition of WHO classification of endocrine and neuroendocrine tumors, the term Hurther cell is not used now, and only the term oncocyte is used for these particular neoplasms. So according to the WHO, what is oncocytic adenoma or carcinoma? It is an encapsulated follicular pattern tumor composed of more than 75% oncocytic cells that lack the characteristic nuclear features of papillary thyroid carcinoma, because oncocytic papillary thyroid carcinoma can also show oncocytic cells. So there should be no nuclear features of papillary thyroid carcinoma and high-grade features like necrosis or mitosis more than 5 per 2 mm square. So why do you need to distinguish oncocytic neoplasms from non-oncocytic follicular neoplasms? First, because there is a morphologic difference between the two patterns, between the two entities. So this raises different diagnostic considerations. The differential diagnosis is different between the two entities. And secondly, there is data to suggest that follicular and oncocytic neoplasms may be genetically different. Like Paxid PPAR gamma rearrangement is seen in 26 to 53% of follicular carcinomas, but they are rarely seen in oncocytic carcinomas. So there is a difference between the two entities morphologically as well as genetically. So it is important to distinguish between the two. So you should note that 16 to 25% of the cases in this category prove to be hyperplastic proliferation of oncocytes in multinodular goiter or lymphocytic thyroiditis. So wherever possible, you should try to rule out multinodular goiter or lymphocytic thyroiditis with abundance of oncocytic cells. Oncocytic carcinomas represent only 15 to 20% of all follicular carcinomas, and as with follicular neoplasms, distinction between adenoma and carcinoma can only be done on histopathology. Molecular testing platforms can be used to help guide the management decisions for FNAs which are classified as oncocytic follicular neoplasms. What is the definition of oncocytic follicular neoplasm? It is a cellular aspirate that consists exclusively of oncocytes. Oncocytes with nuclear features of papillary carcinoma should be excluded from this category. So if you have your features of papillary carcinoma in the oncocytes, possibility of oncocytic papillary carcinoma should be considered. So what are the criteria for oncocytic follicular neoplasms? Again, specimens should be moderately to markedly cellular, and they should consist exclusively or almost exclusively of oncocytes. Oncocytes have abundant finely granular cytoplasm. They have enlarged central or eccentric round nucleus with a prominent nucleolus. No colloid lymphocytes or plasma cells should be seen. So if you have abundant colloid in the background, possibility of multinodular goiter should be considered. If you have excess of lymphocytes, consider a possibility of lymphocytic thyroiditis. Oncocytes can be dispersed as isolated cells or they can be present in crowded groups. Binucleation is common in these cells. Colloid is usually scanty or absent, and sometimes transgressing vessels between the follicular clusters can be present, and if they are present, they are strongly indicative of a neoplasm. So they strongly indicate the presence of neoplasm compared to a non-neoplastic proliferation. Oncocytic cells can also show atypia, which can be in the form of large cells or small cells. So this is the large cells atypia. The term dysplasia was initially used in the previous Bethesda, but now dysplasia term is no longer used. The oncocytic cells can show large cell atypia or there can be small cell atypia. So large cells have abundant granular cytoplasm that are at least twofold, they show at least twofold variability in the nuclear size. And small cells, they have less abundant granular cytoplasm and they have a higher NC ratio. But oncocytic atypia by itself is an unreliable feature for the diagnosis of malignancy, since very marked hyperchromasia, anisonucleosis, and nuclear membrane irregularity of oncocytes can be seen in multinodular goiter and lymphocytic thyroiditis. So just the presence of this large cell or small cell atypia does not mean that it is a malignant process. So we discussed about the general features of oncocytic follicular neoplasms, but there are certain scenarios where all the features of these oncocytic follicular neoplasms are not present. So these are the scenarios where we can have a diagnostic problem. First is if you have a sparsely cellular specimen composed entirely of oncocytes. So the cellularity is very low, but all the cells are oncocytes. There is a possibility that it may come out to be oncocytic follicular neoplasm. So they are categorized as AUS in the AUS category, and reaspiration should be done for better cellularity. The second scenario is if you have a moderately or markedly cellular specimen composed exclusively of oncocytes without atypia. So cellular specimen composed exclusively of oncocytes with no atypia, background is showing abundant colloid. So it is categorized under the benign category. But if you have scant colloid or absent colloid, then some pathologists can call it follicular neoplasm or oncocytic follicular neoplasm, and some prefer to call it benign accompanied by an optional note. And these cases should be followed up by periodic physical and sonographic examinations. Then another scenario is where you can have a clearly abnormal specimen with partial or minimal oncocytic differentiation. So you have a cellular specimen having crowding and overlapping of cells, but the oncocytic differentiation is focal. So diagnostic choice will be between the follicular neoplasm or oncocytic follicular neoplasm. So you have microfollicles, you have architectural crowding, overlapping of cells, but oncocytes are less. So you have to differentiate between FN versus OFN. So according to WHO says that more than 75% oncocytes should be present to be called an oncocytic neoplasm. So if it is focal, then it is preferable to call these as follicular neoplasms if the oncocytic differentiation is less than 75%. If it is more than 75%, we call it oncocytic follicular neoplasm. So this is the same thing. Suspicious FNA less than 75% of abnormal cells are well developed oncocytes, then they should be diagnosed as follicular neoplasm. If you have more than 75% of abnormal cells as oncocytes, you will call it as oncocytic follicular neoplasm. Then the fourth scenario is if you have a clearly abnormal specimen with colloid. So you have a cellular specimen composed of exclusively of oncocytes with atypia, but the background is showing colloid. So if you have watery colloid, then you can diagnose it as oncocytic follicular neoplasms. So oncocytic follicular neoplasms can show watery colloid. So if you have exclusive oncocytes with atypia and presence of watery colloid, you call it oncocytic follicular neoplasm. However, if you have hard colloid in this particular setting, you should categorize it as AUS. Then there are certain scenarios where you can have oncocytic proliferations in multinodular goiter and also in lymphocytic thyroiditis. So if you have flat cohesive sheets of oncocytes, and you also have benign follicular epithelial cells, sheets of benign follicular epithelial cells in a background of abundant amount of colloid, then this particular entity should be categorized as benign and it should not be called as follicular neoplasm OFN. However, all things are not so easy. There is limitation in this classification also. For example, it is possible to aspirate normal follicular cells from adjacent thyroid tissue. So you may have sheets of oncocytic follicular epithelial cells, plus you may aspirate normal follicular cells from the adjacent thyroid tissue in case of Hürthle cell neoplasm. So if you have aspirated a Hürthle cell neoplasm, you are getting sheets of oncocytic follicular epithelial cells, but along with it you have also got, the needle has also gone into the adjacent thyroid tissue. So you also have got benign follicular epithelial cells. So in this case, you may call it multinodular goiter, but actually it is a Hürthle cell neoplasm where the needle has gone into the adjacent benign thyroid tissue. So if you have a minor component of normal follicular cells, you cannot exclude Hürthle cell neoplasm in these cases. So in such cases, radiology is very important. Similarly, some nodules in patients with multinodular goiter may be composed exclusively of Hürthle cells and they may masquerade as Hürthle cell neoplasm. A case of chronic lymphocytic thyroiditis, you can have abundance of oncocytes in these cases. And in these cases, if you have predominant Hürthle cell proliferation in lymphocytic thyroiditis, you do not have any lymphocytes in the background, they may be classified as AUS. So clinical cytologic correlation is very important in such cases, and the goal of FNAC is to provide the clinician with the opportunity to avoid an unnecessary lobectomy in some of these patients. So you may need to differentiate these tumors from certain other tumors. For example, papillary carcinoma, especially oncocytic papillary carcinoma. So it is important to look for the nuclear details. If the details are non-determinable, a category of follicular neoplasm or suspicious for malignancy can be given, accompanied by an explanatory note including the differential diagnosis, and molecular testing can be considered in these cases. Even if the distinction cannot be made preoperatively, lobectomy is often the initial procedure for tumors less than 4 cm regardless of the subtype. Another differential diagnosis for oncocytic follicular neoplasms are medullary thyroid carcinomas. The medullary thyroid carcinomas can present as isolated cells with abundant granular cytoplasm. No prominent nucleolus is seen in these cases, like in oncocytes. On Remnowski stains, the cytoplasmic granules of oncocytes are blue, whereas in medullary carcinoma, the granules will be reddish. Intranuclear pseudo-inclusions in medullary carcinoma can be seen, which are absent in oncocytic follicular neoplasms. And on IHC, thyroglobulin, calcitonin and chromogranin A will be positive in case of medullary carcinoma. Other differential diagnoses are oncocytic differentiated thyroid carcinomas with high-grade features, where increased mitotic activity or necrosis should raise the possibility of high-grade carcinomas, and parathyroid adenomas, which have abundant granular to vacuolated cytoplasm and can be misinterpreted as OFN. So these cases you should look for the nuclear features, look for the serologic testing, and IHC can confirm the diagnosis of parathyroid adenomas. Then certain metastases like clear cell RCC, granular cell tumor can also be confused with oncocytic follicular neoplasms. So management, diagnostic surgical excision has been the standard of care. Molecular testing may be used to supplement the malignancy risk assessment in lieu of proceeding directly with surgery. Mutational analysis is unhelpful in identifying Hürthle cell carcinomas and distinguishing them from adenomas. And unlike other follicular cell derived tumors, oncocytic follicular neoplasms have mitochondrial DNA mutations and copy number alterations, and they have a lower frequency of RAF mutations, while PAX8, PPAR gamma rearrangements and BRAF V600E mutations associated with follicular neoplasm and papillary carcinomas are absent. So this was all about today's lecture. We'll be covering about the diagnostic categories 5 and 6 in the next lecture. Thank you so much.